Hello, everybody, and welcome to today's presentation in the MIRACUM DIFUTURE Kolloquium. I'm very happy to welcome a speaker from my home university, from the Department of Nephropathology and the Institute of Pathology, Ms. Fulvia Ferrazzi. And she's going to talk about the topic we didn't have too much here yet in our seminar series. It's computational pathology, and I know a little bit more about the background of the project. It's about bringing AI models, machine learning models into clinical routine, into the environment of pathology departmental information system. A very exciting topic, and this place is free for you, Fulvia. Just go ahead.
Thank you very much. Good afternoon to everybody, and thanks a lot to Leprocos for the introduction, for the kind invitation. It's a real pleasure to be talking in this colloquium. So the research focus of my group is developing and applying computational methods for the analysis of omics and digital pathology data with the goal to support personalized medicine. Today, I will focus on the computational pathology part of our work, and in particular, as Leprocos already introduced, on our recent work aimed at doing what we called close the gap in the clinical adoption of computational pathology. During the talk, just first that we are all on the same page, I will discuss the concepts of digital pathology and computational pathology, then discuss the challenges that are limiting the adoption of deep learning models in routine pathology, and then I will present the architecture and the components of our proposed standardized framework to deploy deep learning models in a fully digitized pathology department. So by definition, histopathology is studying the disease cells and tissues using a microscope. And we work at the Institute of Pathology, so what our pathologist colleagues are using every day are the so-called histopathological glass slides, and the core part of the diagnostic process is the examination at the microscope, on the basis of which then pathologists can distinguish between different conditions. However, for a sample, in order to be ready for this microscopical examination, it needs to undergo a series of well-controlled steps that I would like to briefly outline from a non-pathology perspective, because I think it's important to follow up the rest of the talk. So in most cases, a sample comes from a biopsy or a surgical resection. Typically, these samples are already put at the source in a fixation medium, such as formalin. They arrive at the institute, they are registered, and then a pathologist performs the gross examination. This is a macroscopical examination of the tissue sample, and the most representative small tissue portions to be then later used for the diagnosis are selected, and they are put in these so-called cassettes, where they undergo fixation and embedding in paraffin. And this results into the so-called FFP, formalin fixed paraffin embedded blocks, that can be used then for sectioning, so cutting of very thin tissue slices that are mounted on glass slides. And then they need to be stained. The default staining that is used is H&E, so this is hematoxylin, eosilin stain. We will see a few pictures throughout the talk. So the nuclei are stained bluish, the cytoplasm and the extracellular matrix pink, and other structures with colors in between. And then these stained glass slides can be utilized under the microscope. If necessary, then the pathologist will order further specialized staining, such as immunohistochemistry stains. In a fully digital workflow, the major difference is that the glass slides are digitally scanned, and the diagnosis occurs at a monitor via these digitized histopathological glass slides, also called whole slide images. However, a fully digital workflow does not only mean the digitization of the glass slides, it also means that samples here, what I just showed, are followed throughout the process with barcodes. This is all documented in the LIS of the pathology department, and often pictures are also taken for quality purposes at different steps of the process, such as, for example, a picture of the FFP material or a picture of the scanned slide. And then the pathologist workspace in this department looks much more similar to our workspace. It's often there is this dual monitor setup where one monitor can be dedicated to the LIS and the other to a viewer for the whole slide images. For us as data scientists, the benefits of having digitized slides are clear, and there have been numerous reports that show how this brings also benefits for patient care. And this discussion would go beyond the scope of today's talk. However, I would like to give you at least this reference from a very recent expert opinion paper from the European Society of Pathology that gives recommendations for a digital transformation of pathology. And in recent years, this increasing availability of whole slide images, together with the computational and hardware improvements that have underlined the current AI revolution, have opened up also the possibility to develop computational pathology approaches that take these whole slide images as input and perform a wide variety of tasks. We can, for example, distinguish between cell-level tasks such as the cells and nuclei segmentation or counting, tissue-level tasks such as tumor detection or subtyping, and patient-level tasks such as survival prediction or prediction of biomarkers. And the computational pathology algorithms that are used, they can either be, so to say, classical machine learning algorithms, where features are extracted from the whole slide images and then a classifier is applied, or they can be deep neural networks that can perform feature extraction and classification directly from the whole slide images. So what I just said is not completely exact, in the sense that these whole slide images are very large, and so they need to be divided into so-called tiles or patches in order to be fed to these neural networks. And then it is these patches that are used as input for the deep learning model. And also for training the model, of course, we need the labels, trained labels for our training set. And depending on how these labels are defined for the training set, and therefore what the trained deep learning model will be able to do, we can broadly, say, distinguish between patch level and slide level models. So patch level models are strongly supervised learning paradigms. Here we need a label for each patch of the training set. In this toy example, we can imagine that we have two different classes represented by these two different colors. The trained model will then be able to output a predicted label for each patch of the test whole slide images. In slide level models, also weakly supervised learning paradigms, here we have a unique label for the whole slide image that is used for the training, and therefore also the trained model will predict a unique label, for example, the presence of a certain biomarker for the test whole slide image that is predicted afterwards. We have previously proposed a deep learning-based model to predict subtypes in upper trait urothelial carcinoma. This is a rare but very aggressive urothelial cancer type. In this case, our training data set was a data set of about 160 invasive UTUC samples. Here, the tumor subtypes were defined on the basis of 6 protein-based markers, and we showed that it's possible to to use and to train a deep learning-based model that is able to reliably predict the two major subtypes, basal and luminals, starting directly from the digitized, routinely used H&E slides. And of course, we are not the only one working on deep learning for whole slide images. In the past years, the number of published models and computational pathology publication has been dramatically increasing. Just to give you an idea of the pace at the increase, here you see the results of a very rough PubMed search that we very recently did to see publications that talk about the use of AI or in general approaches or in pathology. And we think the potential of these computational pathology models is great, and the potential impact on aiding diagnosis and prognosis. And we have had significant examples in the literature of models to predict tumors, presence of tumor in tumor subtypes, but also very recently also publications that show that it's possible to use deep learning-based model to predict, for example, really specific molecular biomarkers or even immunotherapy response directly just from these routinely used H&E slides. However, this potential is not fully exploited. There is still a very limited applicability of these models in the routine pathology practice. So a big gap, let's say, between all this research and a potential clinical use. And we and others have identified some potential reasons for this. So first of all, a fully digital workflow is required in order to be able to use these models. There is still a lack of prospective clinical validation and the regulatory approval for using these AI-based assays. There are difficulties also in the reimbursement for the use of AI, and this also creates a financial burden on the pathology departments. And there are also, so to say, more technical issues, open issues, such as the fact that the protocol for the integration of computational pathology solutions is still missing. Even the publicly available deep learning models are typically not easy to be reused by non-experts, and also the black box nature of the AI tools might also be a reason underlying the limited application of these models. So in our recent work, we decided to specifically tackle these technical challenges. We had the chance to cooperate with Dr. Fragetta, who is a pioneer in the implementation of digital pathology for routine practice. And here, what we developed is a proof of principle framework to integrate in a seamless way the results of AI-based prediction into the routine workflow of a fully digitized pathology department. And this framework relies on HL7 and open source digital pathology resources and also provides a visualization for the results of these models' predictions that are then directly integrated into the LIS of the pathology department. The framework can run in two different modalities. So in the default mode, this runs continuously in the background. So deep learning predictions are run as soon as a new digitized slide becomes available. So therefore, once the pathologist opens the LIS, will already find the results of the deep learning model predictions. It is also possible to run this on demand, meaning from the LIS with drop-down menus, the pathologist can decide what model predictions to run. So, and in order to do this, the first challenge that we addressed is to develop a portable and standardized integration protocol. we relied for this on the HL7 messaging for the communication between the anatomic pathology laboratory information system and what we call the AI decision support system, which in this case was a server running the predictions on pre-trained deep learning models. So the LIS sends a request to the DSS, receives an acknowledgement, the message is processed, the model inference is run, and the QPath project is created. QPath is an open source viewer for whole slide images that was already integrated into the LIS of Dr. Fargetta's department. And then the results are returned, sent back from the DSS to the LIS, and again, an acknowledgement is received. And we thought you might be interested in seeing a little bit more how these messages are structured. So the request is a laboratory order message from the LIS to the DSS. Here in the SPM segment, the name of the deep learning model to deploy is given. In the OBR segment, the path to the whole slide image to analyze is contained. And so how are these deep learning models to deploy chosen? So in the default mode, that is this background running mode, this is done on the basis of a predefined correspondence table between a tissue type and staining and the available deep learning models. And as I mentioned before, it can also, the running of the model can also be done on demand. So initiated by a pathologist by a drop-down menu in the LIS. The results are returned back from the DSS to the LIS with an unsolicited laboratory observation message. In the case of patch level models, this will contain the name of the model, metadata, and prediction for each single type, for each single patch. In the case of binary models, we return also the images of the top 5 predicted types, which are then shown in the LIS patient gallery. And for slide level models, so as I said, these type of models, they have a unique predicted label for the whole slide image and a unique prediction score. So these two are returned, and they are shown in the virtual tray of the LIS inside the slide description. So the description of the slide thumbnail. Currently, there are 16 different deep learning models, mostly publicly available, and some custom models that are integrated. They have been chosen in order to cover a wide range of model types and also tasks, so such as discriminating between different tissue types and conditions, or predicting the status of clinical biomarkers, or also predicting the risk of cancer death. And so after this second challenge of the model integration, we tackle the challenge of providing intuitive visualization strategies to hopefully increase the explainability of the results of these models. And so for binary classifiers, we use measurement maps. In this case, this color code represents the prediction score of, let's say, the worst of the two classes. For multi-class classifiers, we use color maps, so with different colors for the different predicted classes. And for slide level models with attention mechanisms, such as, for example, attention-based multiple instance learning classifiers, we use density maps, which show the attention score predicted for different areas of the whole slide. To give you a little bit more of an idea of how the framework looks in action, we have a very short video. So here what you see, this is the LIS, exactly as a pathologist in this department sees it. On the left, this is the virtual slide tray. Here there are thumbnails of the digitized glass slides. On the right, in this case, you see that some documents have been scanned, and also there are, for example, pictures of the gross examination. Here in this slide, you see that from the slide description says analisi effettuata. This means the analysis has been performed, meaning an analysis with a deep learning model. And okay, now this I didn't test before. Okay, I go back to the normal pointer to start the video. You see the pathologist can double click on the slide, open the QPath slide viewer, and then by going here, the color map, in this case, will be activated. Now on the left, on the annotation tab, it's possible to see the color legend of these annotations, and then one can zoom in and out and also remove the overlaid color map in order to be able to visualize the whole slide image underneath. So altogether with our proof of concept framework, we addressed these three key challenges. So establishing an integration protocol, in this case based on HL7, including a wide range of publicly available and custom models, and also providing more intuitive visualization strategies. Of course, there are some important limitations. So this is still a research-only framework. The question for a pathology department also how to include deep learning-based assessments in diagnostic reports is still open. As I said at the beginning, of course, the digitization of the pathology department is required, as well as potentially an increase in the acceptance and the AI proficiency from the pathologists. And to close, I would like to thank my group, and especially Miriam Angeloni, who has been moving forward our computational pathology efforts. Miriam is sitting is here in the audience today, and we are looking forward to your feedback. I would like to thank our department and the institute director, Professor Amman and Professor Hartmann, and all our collaborators. They are too many to be named all on this slide, but I would like to mention at least Dr. Pragetta, because without his vision, our framework would not have been possible. And thanks a lot to you for listening, and we are looking forward to your feedback and discussion.
Yeah, thank you very much for your very exciting and impressive presentation. It's very rare that we hear something about AI and pathology still. Most of the time, everybody's talking about digitizing radiology images and doing AI on radiology, but this was a fascinating example that similar things can be done in pathology as well. So who has questions to Ms. Ferrazzi?
Nobody yet.
No question yet. So let me just start. When you just click one more time, then we can see your limitations on the slide.
Which I was trying to go back. Yes.
Questions. Have you done some evaluation of the acceptance among the pathologists in the Italian department where the system was implemented? And have you done some maybe just intuitive questioning in the Erlangen department about how this would be accepted? How would you see this?
So in Erlangen, not yet. In the department where we tested the framework, we did a user survey. Now I didn't put it in the presentation. We included the results in the publication. This was a small department. Overall, they thought that also really this framework could really help improve as well as speed up also the diagnostics. We have to say this is a department that is already fully digital for routine since several years. So it is a bit of a biased sample, I think, from the users, but this is where we could do it.
Yeah. You have also mentioned that currently this is only a research-only framework. What does it exactly mean? Is it no longer used in the clinical environment? Was it just in a short period of time for a research project, or what? What does it mean to be only research-only framework?
It mostly means that the AI models, so the deep learning models that are included in the framework, or they were included when we tested in the framework, have not been clinically validated, and therefore they were also not used to make any patient decisions. So this is mostly what it means. However, we hope that the establishment of this framework in this department as well as in others can facilitate like the basis to also really do studies within the proper ethical and regulatory framework to also really more easily clinically test the results of these AI models, because this would allow to really test them also potentially in a larger number of slides and really routinely used, so not in a research-only setting. Yeah.
So at least with establishing this framework, you have done the most important step to give the chance to do the clinical validation of those models. Otherwise, everything would still stay theoretical. So that's a very...
So and this, I mean, of course, this is happening. I mean, this was not part of this published study, but of course, that is exactly the idea. I mean, the framework is established, and therefore it can be used as the basis to then move on for the clinical validation of the different algorithms and of the end of this setting. Yeah.
And then you have mentioned a very important part, that digitization of the whole pathology department is required. You know the environment in Erlangen, maybe also in some other German university hospitals. How far would you think that in Germany we are away from establishing some step like fully digitizing our pathology department?
I mean, it is happening more and more, and now I hear more and more frequently somebody is saying that some clinics or some more practice, they have already done it, perhaps in bigger departments. There are also really bigger organizational challenges to reorganize everything, but it's happening more and more, and I really think in the next few years, so not too many years, then we will have more of this happening. So also in our institute already, for example, we use barcodings already, we have the scanners, so these are also first steps that have to be taken even before then starting then to use it for routine, and these have already happened. So
yeah. Thank you. Is there any more question? No more questions. So thank you very much again for the very nice presentation and the discussion, and wish you good luck for your future research and continuing this work.
Thank you very much. Thanks a lot.
Thanks everybody for listening, and we'll see you next week with a new presentation of Martin Dugas from Heidelberg, who will talk about the quality of life, patient life trajectories. So see you next Tuesday. Goodbye.